Countdown.
I am on the hills, so sometimes my broadband may give, a little bit of trouble.
Okay, no problem. Good evening, friends. Welcome you to this first episode of Jig's Face Off, the Clash of Opinions. This is our new endeavor to start afresh this debate where we will discussing some of the contentious topics, and we have a team of experts and opinion who will opinate on this of the subject, and there will be a clash. So tonight, our subject is, in the opinion of the House, tranexamic acid is a better investment than blood banks in Indian scenario. We all know that tranexamic acid has revolutionized the management of bleeding ever since the CRASH 2 trial was reported. And following that, there were a lot of other trials, the HALT IT trial, the WOMAN trial, etc., that has no doubt established tranexamic acid as a formidable weapon against in the management of bleeding. But at the same time, it has also raised some eyebrows and some questions. Tonight, we are going to witness a debate on the subject, and we have as members of the Treasury bench, Dr. P.L. Gautam and Dr. Pooja Murthy, and in the opposition bench, we have Dr. Narendra Rungta and Dr. Monalisa Mishra. We have as our jury tonight Dr. Pradeep Rangappa, Dr. Ajit AK, and Dr. Kapil Dev Soni, and I will be moderating this debate. And we will hear some lovely, interesting bites on this important, contentious subject. So without wasting any time further, we are moving on to our debating scenario, where we invite from the member of the Treasury bench, Dr. Pooja Murthy.
Hello, everyone, and thank you for the opportunity. Can I share my screen, please?
Yes, please.
So, a very good evening, everybody. I think all of us know tranexamic acid. All of us have read about it. I don't want to bore you with some data. So, let's listen to a story first. All right. So, Indian scenario, tranexamic acid is a better investment. Definitely, yes. And how do we go about it? So, I will tell you a superhero story right now. What or who is tranexamic acid? It is our very own Indian superhero like Shaktiman. Yeah. And what is it? It's a synthetic antifibrinolytic agent which inhibits plasminogen activation and thus improving the clot strength. What are the superpowers it has got? It stops bleeding in various conditions. It could be trauma, it could be surgery, it could be obstetric hemorrhages. Let's discuss about the superpowers of preventing bleeding and trauma. All of us know about the crash 2 trial, which is a landmark trial published in around 2010. 20,000 patients who were randomized to receive tranexamic acid as per protocol within 8 hours of surgery, and especially for patients who were bleeding or who had a significant risk of bleeding, especially who had hypotension, tachycardia, and all that. And what did we find? We found that the all cause mortality at 28 days was lower. This was much better if it was administered within the first 3 hours, and especially within the first hour, where the relative risk reduced to around 0.68. And coming to the problems with tranexamic acid, we always and unnecessarily blame a knife agent, and there was no significant no increase in any events, thrombotic events like MI, stroke, P, etc. Coming subsequently to the crash 3 trial 2019, here again a large multi-center trial, similar protocol as per the crash 2, but it was tested in patients with traumatic brain injury. even though all cause mortality was not different, but a subgroup of patients with mild to moderate TBI who received tranexamic acid early within 3 hours showed benefit. Here again, there was no major vascular events that was noted. We all may argue that these are old studies. Does it stand good in the current scenario? We have recent trials like studies like this one, which was published as latest as April 2025, which reconfirmed the benefit of tranexamic acid in trauma. Another study again in 2025 showed that there was a significant mortality benefit if it was given within 90 minutes of trauma. Not only trauma, in pre-hospital settings also it has shown significant benefit. We have various meta-analysis. We have a trial called the patch trauma trial, which again showed tranexamic acid was much better when administered early. Now, another meta-analysis showed that not only did it improve the 24-hour mortality, but also reduced the need for transfusion. So, on an average, around 2.3 units blood products were lesser in patients, even with major bleeding and massive hemorrhage, who received tranexamic acid. So, it is not only saving lives, but it is also saving the blood components. Coming to perioperative settings, again, the second superpower of our superhero. Undoubtedly, it has been tested in various surgeries, non cardiac surgery, it could be orthopedic surgeries where we anticipate blood loss. The composite bleeding outcome when tranexamic acid was used perioperatively showed significant decrease in bleeding. And again, there was no major cardiovascular or thrombotic events that was noted. And unnecessarily, we keep blaming the superhero that he's inefficient, he's harmful, and all that. Coming to the most important part, the third most superpower is to prevent obstetric hemorrhages. Data from the the Indian data, which shows that 70% of the obstetric of the maternal mortality happen because of obstetric hemorrhages. So, tranexamic acid has become the holy grail and one of the most important armamentarium in managing obstetric hemorrhages. The landmark women trial showed significant benefit when administered within 3 hours of delivery. Not only that, the WHO has recommended tranexamic acid as a standard PPH treatment package, and it has also been included in the WHO essential medications list. Not only that, it is inexpensive, it doesn't need any special storage, and it is very easy to administer. What about Indian data? Indian data, various studies in various settings have shown significant benefit in terms of reducing bleeding and reducing mortality. Coming to the villains, why are we talking about the superhero when we don't know the villain? The villains here is blood loss, lack of blood bank facilities, especially in our country, and timely non-availability. Even though we have blood, we may not get blood on time. That is the whole sad story about our situation. What does it do? All these villains will lead to death of our innocent victims. What are we talking about? A significant supply-demand mismatch. The annual requirement of our blood is around 14.6 million units per year. If you just number to number, if you compare, we are short by around 1 million units, but this is just the tip of the iceberg. Almost more than 49% of the blood banks, or more than 50% of the blood banks, do not have a component separation facility. And not only that, the amount of wastages, so because of expiry, storage, or quality issues, etc., around 1 million units are wasted annually. Even various newspaper articles have noted that our enemy of blood, lack of blood, is becoming stronger. As we can see here, more than 1 million units every year is discarded just because we do not have proper storage facilities, just because it is not being used appropriately, because of non-availability at the right time and right place. And again, this we fall into a loop of blood shortage in our country. What are the challenges? Regional disparities, a significant difference between urban and rural population where blood bank facilities are available, wastage, large demand, and infrastructure problems. You can imagine just a storage facility, not even a blood bank, needs 24 into 7 electricity. Do we have the capacity to provide that in the extreme rural settings? Do we have backup generators in all these places? We do not. And there comes the problem. Even though we say in the recent process in 2025, they say the gap or the demand supply is being matched, it is still again not a full information, because as we see here, 16.2% of people are not within 30 minutes walking distance for a blood bank. 63 districts in India do not have a single functioning blood bank at all. And what are we talking about? Blood banks and tranexamic acid and all these things. We do not have a functioning blood bank at all. And as per Times of India report, Karnataka alone, 44,776 units were discarded in 24-25. Even though we can match this, what about affordability? In the least of the least settings, it costs around 4.5 to 5,000. And in some private sectors, which I found out, the whole single amount of blood unit transfusion, along with the cross matching charges, nurse charges, will come up to 12 to 15,000 per unit of blood transfused. So you can imagine the cost. Even if you have blood, people cannot afford it. The biggest villain of this is cost. What is the cost to set up a blood bank? It is very high. It runs in lakhs to crores. I found a report when I was trying to understand a Jharkhand NACO blood center project was being planned, and they tried to calculate the cost. To just the construction cost is 25 lakhs, equipment cost is 35 lakhs, recurrent cost per month is around 4 to 5 lakhs. So easily the minimum amount of money needed for a single blood bank facility comes up to 60 lakhs. And can you imagine that? What is the cost of tranexamic acid? By the way, I just Googled this, any of the online pharmacy stores. For 500 milligrams, the cost is around 56 rupees or 27 rupees, just, and not more than 100 to 200 rupees is needed for the entire dose of tranexamic acid. And we are talking about 60 lakhs as a minimum basic to set up a blood bank. Even the crash through economics trial has shown significant benefit in terms of cost reduction. Savings, happiness. Are we not happy when we save? Even our Prime Minister recently, when he announced slashing of the GST rates, and even like recently, yesterday, when I went to a grocery store, it saved me at least 1,000 rupees, and I'm really happy about it. So, any saving is happiness, even though we feel it may not replace blood banks, but we, of course, all the time save on transfusions. So what is the total cost of tranexamic acid? Not more than 200 rupees. Cost of blood transfusion, a minimum basic of 5,000, it may go up to 15,000. As our pre-trauma tranexamic acid meta-analysis has shown, at least 2.3 units of blood product requirement is reduced. Forget mortality, forget blood banks. It also reduces the need for transfusion. And if you do the math, it reduces the cost that is required by we save at least 12,000 rupees on a single blood transfusion minimum. So, but what is the cost for life saved? It's invaluable. So we are talking not only about monetary basis, we are talking about saving lives here. To conclude my points, tranexamic acid has undisputedly shown benefit for blood transfusion and also preventing death. In our country, we face a significant demand supply mismatch, and cost of setting up blood banks is paramount. The complications which we always blame about thrombotic events is all fallacious, and it has not been significantly shown in major trials that it increases the thrombotic events. And even though we feel it may not replace blood banks, if some of you feel it may not replace blood banks, but it surely will bridge the gap in our country. And I would like to stress here that investing only in blood banks and not being aware of measures to reduce the demand itself is like living is like you are.
Okay, thank you, Pooja. I think Pooja has ended. I share her unstable internet. I think that's why she is not even able to. So that was a very good start with a lot of fireworks of the first 6 overs that people normally see. And Pooja is like the opening batsman Smriti Mandhana, who has been able to hit a few more sixes than boundaries. Now we will go to listen to Dr. Monalisa Mishra, who is from the member of the opposition. Yes, Monalisa.
Sir, I'll share my screen.
Yeah.
Okay. I think Pooja is still sharing. So
No, she's not sharing. You can click.
okay. Yeah. Okay. So my topic is Tranexa a better investment than blood banks? And I have to speak against the motion. Thank you, judges, for making it easy for me because ideally this debate shouldn't exist. Why? Because a fire extinguisher cannot be compared with a fire brigade. Tranexa can slow bleeding, but it can never replace blood. Blood is life. Oxygen transport, clotting, survival, everything needs blood components, not Tranexa. It's a global practice. No country has ever replaced blood banks with Tranexa. They complement each other. So that is why I feel this debate shouldn't exist at all. So Tranexa versus blood bank is a false premise and better nip it in the bud itself. So I have already said Tranexa is not equal to blood. It can save some lives quickly, but it will not sustain lives daily. Tranexa can reduce bleeding. It's a quick intervention. It is not a blood substitute. Blood bank provides comprehensive blood components for various illnesses. It is important for sustained life saving. It restores oxygen, clotting, volume, and what more. So, what does the latest evidence say? My opponent, Dr. Pooja, has already mentioned about crash through trial and woman trial. So, early Tranexa reduces death from bleeding. We all agree. Most effective when given within 3 hours of injury. We all know that. And it has also demonstrated significant mortality benefit in bleeding trauma patients. Also, in woman trial, in PPH, it reduces death from postpartum hemorrhage if it was administered within 3 hours. But in all these cases, timely intervention was extremely crucial. And also, everything was done in the background of having a robust blood bank service. None of these hospitals did not have a blood bank service and they were experimenting only with this drug, that is Tranexa. So, what is the limitation of this drug as a blood substitute? It only reduces fibrinolysis. It doesn't restore blood volume or hemoglobin levels, which are critical in severe blood loss and anemia. It is showing only time sensitive efficacy. If we are not aware that we have to give it within 3 hours, then it's not beneficial. And it is not useful in a chronic situation where there are ongoing transfusion needs for patients who have chronic conditions like thalassemia or they're undergoing any hemato-oncology treatments. Also, there's a risk of complacency that if we rely too much on this drug and forget to make our blood bank national blood supply more robust, we will be falling really short of blood products when we need them. So it is a valuable adjuvant. I agree with my opponent, but it is not a replacement. It can reduce bleeding by preventing clot breakdown through plasmin inhibition. We all know the mechanism. We have seen proven benefits in high-risk cesarean deliveries in a recent RCT in 2022. Also in CRASH 2 trial, it showed benefit. It is low cost, heat stable, straightforward, easy to administer, but it cannot replace blood. So what are the critical limitations in Indian healthcare? It can reduce bleeding, but cannot replace blood in severe hemorrhage and anemia situation. Effectiveness will depend only on timely administration, often impractical in Indian rural healthcare infrastructure, and doesn't provide oxygen carrying capacity or doesn't replace the lost blood volume in critically ill patients. So as it was said, it is cheaper and easier, but we are dealing with human lives here, so we cannot focus on cheaper and easier. So cost versus functional analysis, while it appears to be inexpensive per dose, it cannot replace multifaceted life-saving functions of blood in clinical practice. Clinical systemic healthcare needs, blood banks serve multiple clinical requirements beyond simple hemorrhage control, and they support comprehensive patient care. And investing solely in Tranexa will ignore the systematic failures causing chronic blood loss shortages across the country. And strengthening blood bank infrastructure improves the overall healthcare of the system and not merely the bleeding management. So Tranexa reducing transfusion need. Now let's deal with that. So limitation in severe cases, it can reduce blood loss, but of course you will have to transfuse eventually. Clinical trials have demonstrated that it reduces bleeding, but inconsistently affecting the transfusion rate across different healthcare setup. Blood transfusion remains absolutely essential for oxygen delivery and volume replacement in compromised patients. It is a valuable adjuvant therapy, but not substitute for safe, reliable blood supply infrastructure. So what is the verdict? While Tranexa offers vital adjuvant therapy, robust blood banks form indispensable bedrock of our health infrastructure. Universally, blood banks have a life-saving impact because investment in blood bank delivers immediate widespread impact, saving countless lives all across the conditions, emergencies, and demographics. It is important to strengthen our blood bank, drastically reducing the infection rate, elevating the patient outcome, and advancing the crucial public health objectives. Indian healthcare future hinges on commanding robust blood banks and strategically complementing it with targeted Tranexa implementation. So my final slide is blood banks are your survival backbone. They provide oxygen carrying capacity, clotting factors, and platelets are not just blood. Tranexa is only a supporting tool. It will reduce bleeding, but it will never replace blood. It's not Tranexa versus blood bank. It is always Tranexa plus blood banks. So strengthening blood bank system is our first priority, and using Tranexa as an adjuvant is our next priority. In Indian context, blood banks are foundational, and Tranexa is only a brick, not a building. So I like to conclude by saying, it's essential. Tranexa is essential. It is affordable. It is evidence-based, but it cannot replace life-saving day-to-day chronic role of blood banks. India's strategic investments must prioritize blood transfusion services while deploying Tranexa within strengthened care pathways. So a sponge, Tranexa is like a sponge. It can absorb some water, but it cannot plunge a broken dam. It can help, but blood bank saves. Thank you. Thank you, sir.
Thank you, Mona Lisa. Mona Lisa has strongly defended her position. And now we are moving to the senior counsels of the two sides. From member of the Treasury bench, it is Dr. P.L. Gautam. Yeah, please unmute yourself, Gautam, sir.
Good evening, sir.
Yeah.
Good evening, Dr. sir.
Good evening, Parshottam.
So,
sir, if you switch off the video, if you switch off the video, maybe the voice may be more clearer.
No. It is fine.
No, it won't be.
Here we can hear.
Okay. Yes.
first thing is I must appreciate the sincere attempt by Dr. Mona Lisa. But the thing is, facts remain the facts. Truth doesn't need much of evidence actually. She said three things in the total talk. I would say, if fire brigade cannot, fire extinguishing is not required. If the fire in the kitchen is there, fire brigade cannot come immediately. You need fire extinguishing because it's not possible every year fire brigade can reach, and it takes time to. Fire extinguishing is very ready, available, and it's the rules and regulation ask for this thing. So that the need evidence is no more, and the timing she already said. That's again the same sentence I would say. She has to make the things easy for us. Blood bank investment and the Tranexa or tranexamic acid investment and defibrillators. I think she also spoke the same thing. Now let me share the slides also. You can see my slides now. So I will be, evidence already has been given by Dr. Pooja. Now the question is here, the thought process. What about the need of both facilities, tranexamic acid and the blood banks? Then I will talk about the essentiality of both and comparison of investment cost versus cost effectiveness also, and the evidence. Let's take, I won't be taking this already everyone knows. I will just skip production, but these 12 have been spoken. Now coming to the actual, sir, it is not direct apple to apple comparison. It's not substitute each other. You must understand. There are two different investment approaches complementary to each other in the healthcare sector. The Tranix asset is a pharmaceutical invention which reduces the blood loss and need for transfusion should be considered essential irrespective of blood bank availability. Blood bank is medical infrastructure with numerous invested manpower, machinery, wastage in addition to many adverse effects too. We need building, we need equipment, we need power backups. In India, you can imagine the powers and the staff and availability of the doctors and technicians and the clinical staff. It's very difficult to have all those things in the periphery. Another is permissions, it is to rules and regulation, maintenance, and operational cost. If you have to give very safe blood, you have to have a very fantastic testing, which will cost like huge if you have to violate. Even then, the risk is there. When the public believes in the blood ratios to maintain the camps and other things required. And there's so many things, it's not that easy. Now coming to the investment in the next step. Tranexamic acid is highly effective to reduce blood transfusion mortality and overall health cost. I mean, everyone knows it. So blood bank is essential, but even there, the blood bank is there, we need tranexamic acid. We need antifibrillators even if the blood banks are available. Let's take something like if you have high risk surgery, we all just want to take the examples. Then moderate risk surgeries or emergency or low risk site. I mean, there are multiple dimensions of blood loss. Let's take one example, simple. If we are sitting in the periphery, like normal cesarean section is there with PPH, bleeding is around 500, 1 liter bleeding is there. We have two options, two scenarios. One is patient may require one or two transfusions. And smart teams like to avoid that too. Single transfusion is no transfusion as per the all blood bank societies. And patient may bleed like anything requiring massive transfusion protocol. Any blood bank in the periphery, is it possible for that to give the massive transfusion protocol? Get blood from a far from bank transport is a problem. So it's not feasible also. But we need to store these blood banks with the running asset or maybe any other defibrillator. And if you see the cost effectiveness as per the WHO and other societies, even NHS, all, they have very clear cut guidelines for this thing. You may have a blood bank, but even then you have to have it and defibrillating the practice in the blood conservation techniques. Thus, patient blood management is good value for money. So best practice and certainly of this. Adopting a restrictive transfusion strategy and the administration of tranexamic acid will likely be highly cost effective. Intraoperative cells and maybe the cost effective used in the patient at high risk of bleeding. So now coming to another thing, we are expecting that down the line another decade. Is it possible to have the blood banks in all the setups? Even if we take blood banks, is it possible to have the operational functioning those things and physical? And maintaining it for a long time and without wastage, it's not possible. And why give blood if you can prevent the bleeding, if you can stop the bleeding with other things, or even if you can download the load, even that is good. And talk of something more than that. Let's have an example where the patient is bleeding like a massive blood loss. Let's assume that we are sitting in advanced center. We are talking the periphery. Let's be in like an institute like PJ Ames or BMC or any big institutes. Even then, going with the major surgery like cardiac surgery, liver trauma, and getting liver transplant. So, do we need like to have practice blood conservation technique? Everyone will. Why not? If we can try to, we can avoid blood has its own side effects. It reduces the immunity. It has multiple. It can lead to trolley. It has so many complications. Then availability of blood bank doesn't offset the investment of blood conservation strategies. And it's not that blood, we cannot live without blood. Jehovah's Witness patients, although a small group, bloodless surgery protocol there, bloodless conjunctivitis are used, and people have found that there is less mortality and morbidity in Jehovah's Witness patients. So why not to practice for everyone? What we need is experienced teams and careful strategy. So why not invest in those things which are easy and safe? And let's the ethical debate about the two approaches. Patient may not accept blood, and we don't like to give blood also. There is a risk. Beneficial blood may be life-saving in some, but not all. It carries risk. And if you go to the third principle, malfeasance, the search have been working for years to avoid and minimize transmission with the pre-preparation, autologous transmission, cell savers, artificial blood, and tranexamic acid is one of that. And why not to practice it? If we can avoid transmission using tranexamic acid, it's not just to avoid unnecessary transmission which can be avoided. So now coming to the other thing, investments. Already Dr. Pooja has given very nicely that it's a cost-effective blood bank. It requires a huge cost and operational costs also. So what to do without bias? For maximum immediate impact and cost, and especially in addressing specific high burden conditions like PTH trauma, investing widespread availability, use of tranexamic acid is a superior option. It's a smart, low-cost intervention that reduces the overall demand for blood products. For building a robust long-term healthcare system, investment in blood bank infrastructure is not negotiable. Its foundation, service, that cannot replace. But that doesn't mean the investment. If you go with the investments, I think it's a better investment to conclude the most effective study, not to choose one over, but to pursue a patient blood management strategy. This approach use of cost-effective like tranexamic acid to conserve blood alongside a well-funded blood bank. The combination maximizes the patient outcome. And trans is a never-ending success story of sharing with the other blood. It's the hematology society for society and the blood. Everyone gives a green signal and an edge over blood banks to tranexamic acid as far as investment is concerned. Investment is always not in the terms of that what is good or bad, what is essential. Investment is an option where we can have the cost of it. Tranexamic is not, the debate is not against that we should not have a blood bank. The debate is which investment is cheaper, one economical, which has to be there. So there is no comparison. Already this slide has been shared. Even the meta-analysis that everything says that this is a better option.
Thank you, sir. Thank you. Gautam sir has further solidified the position of tranexamic acid and made task difficult for Narendra Rungta sir. But Narendra Rungta sir is a veteran and winner of many debates and many battles, and therefore he will definitely come up with proper response. We are waiting to hear Dr. Narendra Rungta against the motion as a member of the opposition bench. Rungta sir.
Thank you, Anirban. I hope everybody can hear me.
Yes.
Yes, sir. Very clear, sir. You are very clear.
Okay. Thank you. And congratulations to the organizers for a wonderful session. And thank you for inviting me. Though, it is not fair to be in the opposition where the battle is already lost by the treasury benches. Because I must compliment them for, fighting the battle very graciously. And trying to defend a motion which was undefendable right from the word go. Still, they tried. Pooja was a little bit aggressive, but Purushottam surrendered right from the beginning, and he was trying to manage, here and there, both TXA and blood banks. This is good, this is better, complement, substitute, He was trying to shy to say that blood bank is a bad investment. However, I like Pooja's presentation. She had a superhero with superpowers, benefits, and she mentioned about shortages of blood, shortages of storage system, and poor India. She was quite critical of poor India, cannot afford blood banks. So with that background, and I must also congratulate my colleague on my side, Dr. Mona Lisa, who just nipped in the bud the whole debate. Congratulations, Mona Lisa. And you needed to do that, and that was a fair statement that that debate should not have existed at all, and you nipped it in the bud. Let me share my slides. So I hope my opponents will have a heart to look and hear what I'm saying. Suno, 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 new slogan. Shun blood banks, donate tranexamic acid, create TXA banks. Sounds wonderful. On the street sides, markets, let the trumpets blow and shun blood banks. Opinion of few, not all, definitely not mine. I am vehemently opposed to it. And I have put the name tranexamic acid in a tricky manner, as the debate is so tricky. This is a Trumpist statement, I thought. Making a statement like President Trump does, he says something today, just opposite tomorrow, takes a somersault by the time he wakes up next morning, or it may be just a wild or loose statement, or a leisure time joke. Are you kidding, Purushottam? I don't want to talk about it. Everybody has spoken about it. Blood is life, my dear friends. Tranexamic acid is just a drug, a medicine. So you want to compare life with a drug, a formulation? It was developed in 1960s only. And it's still, you need to have trials, RCTs, every 5 years, every 3 years, crash 1, crash 2, women trial, and so on. And how about trials of blood transfusion? Did you hear any blood transfusion trials, whether blood transfusion trials are needed to save lives? I don't think. There are trials concerning components, there are trials concerning group matching, but not about need for blood transfusion. Dr. Bernard Fenders, who developed the first hospital blood bank in 1937, his soul must be so disappointed at today's discussion. Purushottam, he is going to come into your dreams today night and ask you a few questions. Blood has no substitute, my dear friends. It is indispensable, and so are the blood banks. And therefore, TXA is just another dispensable molecule. And maybe in 10 years' time, I will mention to you, I'll be in a position, if I am around, that tranexamic acid has disappeared from the scene and it has been replaced by a new formulation. Blood is not going to go anywhere, and so will be the blood banks. Many of us still don't use it. And many of us can still argue ferociously in favor of its limited application. A large part of India's and world's population may not have access to tranexamic acid, still they are surviving. They are surviving trauma, they are surviving surgeries, they are surviving bleeding disorders. They did not need tranexamic acid to flourish, to live full life. It acts, my dear friends, only if blood is there. It only stabilizes clot. It does not form the clot. It stabilizes the clot. Therefore, you need blood. If there is no blood, tranexamic acid will not act. It is useless in absence of blood. Clot will be formed only if all ingredients required for clotting are present. TXA only stabilizes it. It does not need our emphasis that these ingredients are available only in blood, not without blood. It's unfair to call blood banks just an investment. This is a bad phrase. It's a movement. ये आंदोलन है which started in early part of this last century and it is still carried on. Number of blood banks have multiplied lakhs times in India since independence, lakhs times. From less than 100 blood banks, number of blood banks have multiplied to several lakhs in our country. It is mandatory requirement for any ICU to be level, and you are all ICU guys. Can your ICU be level 3 without a blood bank? Does any inspector ask you ever, do you have TXA in your blood bank, in your ICU? If you don't have, I will disqualify you as an ICU. So that's not an essential part of the blood bank armamentum. I sent a question to my friend Professor Rupen Arya, who is Professor of Thrombosis at King's College London. Professor of Thrombosis at... My question was, what are your comments about application of tranexamic acid? I did not tell him that it's versus blood banks. So he would have laughed. Reply, after recent trials, we use it widely, usually as an adjunct. So that means it is not a mainstream formulation. It's an adjunct, dispensable adjunct, which can be dispensed with, which is not mandatory. Blood banks have saved billions of lives since their inception in 1937. Work and research is still on to still make blood banks more rewarding. No one can claim that a particular patient was saved because TXA or a life was lost because TXA was not used. I don't think anyone here from the Treasury branch can give me a proof that a particular patient died because TXA was not available, or a particular patient was saved only because TXA was used. They will never be able to give. They will only got crash trials, crash women's trials. We all know that these trials are promoted, motivated, and supported by industry. Therefore, you know what happened to Eli Lilly's wonderful wonder drug of sepsis? You never know. Therefore, we strongly oppose even the thought that promotes storage use of TXA as a substitute of blood or blood banks. A word about current Indian scenario. Pooja was quite apprehensive of India's ability to build required number of blood banks. What is the problem? We are the largest growing, fastest growing, and the fourth largest economy in the world with third largest foreign currency reserves. With largest railway network, third largest number of airports and civilian aircrafts in our country, fifth largest automobile producer, first country to reach the south pole of moon, a country which supplies vaccines to the whole world. We are also called pharmacy of the world. India by no means is a poor country anymore. It is only the mindset, calculations of the politicians and bureaucrats which have prevented erection of blood banks throughout the country. And I am guaranteeing you in next 10 years that 50 odd districts Pooja has mentioned will have blood banks, not only at district level, even at the taluka levels. Blood bank created today will save thousands of our brethren tomorrow and always. If there is enough blood, there are enough number of blood banks. Our soldiers feel confident at our borders that there are billions of donors in our country who will come forward, donate blood, and blood banks will store blood for them and they will be saved. There were no better times in India than today. It is a sacred investment, I would say, than ever. I am surprised unpleasantly and shaken with decision of my worthy opponents trying to defend the motion. I would have expected my friend Purushottam to politely tell the proposers of debate to recuse himself from the debate. They lost it when they accepted to defend the motion. You still had a chance, Purushottam, 30 minutes back to disappear from the debate, charging your fees like a smart advocate. Play truant when you are sure that you are going to lose in the court. It is just undefendable motion. So, thank you very much, everybody.
Thank you, sir. Thank you very much. So nobody could have nailed the coffin. So largely like Dr. Rumta. So I could see that sir tried every possible nails to be pinned against the coffin. But still we have to hear from our jury who have heard both sides and they will finally come up with a verdict. But before that, since we have amongst us as a panelist from a different specialty, Dr. Shobha Kudi, who is the president of the Bangalore Obstetric Society, I will just, by the time the jurist decides upon their verdict, I would just invite Dr. Shobha Kudi to give a quick comments. I think Madam would like to restrict her comments to PPH on Tranexa. It will not be fair for us to expect from neuro or other causes of bleeding. Yes, Madam.
Thank you
Please share
so
your
much,
thoughts and
Dr.
experience.
Anirban.
Yeah,
I think
please.
it is very difficult to make place for an obstetrician amidst people who are kind of, going after each other with whatever they have. Very, very exciting to be part of this team. And I have always been attracted by critical care. And I think Dr. Pradeep gets a call from me every few months, I think, and it will become more so in the coming years.
Yeah, Madam.
So very kind of you to have joined,
So
madam.
then,
Thank you
The
very
woman
much.
trial,
I think
Lancet
for
27.
obstetricians, the roadmap is very clear. We have absolutely no doubt that tranexamic acid actually is of high benefit for women, both who are suffering from postpartum hemorrhage and who are at risk from postpartum hemorrhage. The only one cohort actually in obstetric hemorrhage where it has been counterproductive is those women who have suffered antepartum hemorrhage and they go ahead and deliver. In them, we are very cautious, but otherwise, because they would have suffered some morbidity and immobilization before birth itself. In them, we are very cautious. There are very few contraindications for us because at admission, we always rule out thromboembolism in the past, in the personal history, also in the close relatives. Any hypersensitivity history also alerts us. But apart from that, we do not find any contraindication for tranexamic acid, even in the face of hemorrhage. And of course, it is totally complementary to the blood transfusion, blood products. The ROTEM and the TEG reports are awaited. Till then, we can definitely use 1 gram of tranexamic acid. There is within 3 hours of any hemorrhage is the best. After clamping of the cord as early after cesarean has been proved to reduce the blood loss of cesarean also. So the woman 1, woman 2 trial, even though it might be said that it was industry driven, has shown a reduce in all-cause mortality, not just from hemorrhage. And so we are very convinced. Why we are convinced also is because we see the results, because we are practicing it. So we see the results. About it being an industry-driven project, when we look at the play of management of hemorrhage, we feel that blood banks and blood components are very highly ambitious and very profit-driven institutions today. And actually, they are all doing very, very well, and they are priced quite well also. And even those who are at low resource capabilities, once we tell the family that blood is required, they run and get it. So resource doesn't matter when it comes to blood and blood products. Tranexamic acid does not add that much because we do not use beyond 1 or 2 doses. So for us, the evidence is level 2B, grade 2B. and higher. And I think there are some more trials which are coming up. So our conviction is very much there. And I really enjoyed the panelists' deliberations. And I could also gather that in their minds, they were also looking at the two modalities as complementary rather than, one instead of the other. So I think I should rest my case.
Thank you, madam. Thank you. Now
very
I would
much.
I would go to the jury for the final verdict. I will start with Dr. Kapil Dev Sori. Yes, Kapil, your verdict based on what you heard from members of the Treasury and opposition.
Absolutely, means I work in a trauma settings and we get patients of trauma day in and day out. We have been extensive user of tranexamic acid since the CASH2 trial was done. Actually, we were part of that CASH2 trial. So one thing is about tranexamic acid is the time limit. We still give it even if the patient comes very late, but we know that it's not effective. So the only effectiveness is once you administered very early stages of bleeding, and as rightly stated by Dr. Rungta, that you need a clot to get stabilized. So for that you require a blood. There is no substitute of blood as if now. Having said that, as Dr. Rungta clearly elucidated, that we are in the third largest economy. We have so many airports coming up. We are progressing, but it's also a fact that we live in two Indias. If you go to rural settings, you may not find access to even basic healthcare facilities. So another problem which I see with tranexamic acid is the penetration. They are still little hesitant to use, but I believe that if we can use it, as it's very clear that it will never be a substitute of the blood, but it has to be used very early stages of injuries or early stages of trauma, where a lot of patients can given. So as like we give it adrenaline, or we use it like atropine, adrenaline, which are life-saving drugs. This drug should also be considered as one of the part of the life-saving drugs. So that's an issue. But there's no doubt we need a lot of investment in blood bank. We need a better blood banks. We need a faster blood bank. We need a cost-effective blood banks, and may not be the blood bank infrastructure, but process-wise, we do need little access to the blood. Blood is a gold mine. Means you cannot replace blood as if now there are no proper blood substitutes available in the country anywhere in the world.
Thank you, Kapil. I go to move on to my second jury, Dr. Ajit. Ajit, AK.
Yes. So I believe that, after listening to both the sides, I believe that, the tranexamic acid and, blood supplementation is basically both are complementary. See, for example, India, like, Dr. Kapil has mentioned, India is a country with different, different worlds. And basically the maternal mortality rate, I mean, it is quite high in India, maybe around, 140 or something, maybe around 10 years ago. Now it is around 88 to 90 for 1 lakh live births. Now that kind of a very high maternal mortality. And one of the most common reason is postpartum hemorrhage. So coming to the tranexamic acid is concerned all across the India where the treatment is given, and you cannot have blood bank. When PHCs and all, you can't have blood bank. So naturally, it's an essential medicine by the WHO, and I believe that the government of India also has made an essential medicine, just like adrenaline or whatever kind of a steroid, basic hydrocortisone or something. It should be an essential medicine, and not available. Not this particular medicine not available should be I believe should be considered as a medical, whatever, lack of medical diligence or negligence. That I realize. So it's a very essential medicine. It is definitely going to, especially as a first armamentarium, before you transport such a patient, it is going to help it. And we know that it's going to decrease the mortality, the decrease, the amount of transfusion what is being given. But I have a small addition to that. So basically, this tranexamic acid, just a thought actually, tranexamic acid is a anti-fibrinolytic agent, anti-fibrinolysis. It is inhibiting the fibrinolysis. Basically, see, there are 3 conditions which I can confidently say, because that, where you can have hyperfibrinolysis. Number 1 is trauma. Other thing, they say the liver transplant patients, and liver transplant recipients, trauma patients, and post CABG patients, post cardiopulmonary bypass patients, they can have a lot of hyperfibrinolysis. So if you are able to identify this hyperfibrinolysis, whatever we usually do we do some kind of the viscoelastic testing, the TEG sort of thing, like we do that. If you're able to see that, if you give the tranexamic acid, it's going to be, definitely it's going to be extremely useful because it's an anti-fibrinolytic agent. It's going to inhibit the thing. It's going to reduce the bleeding. But if you look at the trauma literature, Dr. Kabil may be knowing better. They say that at least around 30 to 60% of the people sometime, instead of hyperfibrinolysis, which we are expecting and we are talking about, you can have fibrinolysis shutdown. So what I mean is that there is no fibrinolysis not happening. In those cases, supposing you without knowing the hyperfibrinolysis happening, if you give the tranexamic acid, it is going to probably harm or not is one thing we need to really think about. And I know that in DIC case, obviously it's an anti-fibrinolytic agent, so that means it inhibits the fibrinolysis. So that means it increases the fibrin formation. So there can have there could be some kind of harmful effect, or it may not be very strongly recommended where the DIC is sitting. This could be the thing which we need to be aware. But otherwise, I believe that both are very complementary because reducing the thing is the transfusion thing, reducing the mortality is very great, and this is an essential drug. There is nothing like that. Just like oxygen, whatever you call like the basic thing. There is no dispute that this drug is very essential, and obviously it cannot replace blood, but they are both are very much complementary. That's what it is. And obviously, when you reduce a transfusion, it is definitely going to reduce transfusion associated infection and the trial reactions, and it is definitely going to benefit the patients.
Thank you, Ajit. And finally, I move on to my final jury, Pradeep. And after that, you want to cast your vote, the jury, because if you cast your vote, then someone will win and someone will lose.
Would you allow me 2 more minutes after the jury?
Yeah, final. Once yes, Pradeep, you can.
Because I may still pray to the jury.
Yeah, so
Yes,
good evening, friends. Good evening, friends. Actually, at the outset, I wish to applaud all the presenters. I think they have done phenomenal work, and a lot of effort has been put by Pooja, Mona Lisa, and my pranams to Narendra Rungta sir for so excellently encapsulating the debate into real sort of a judgment and a jury sort of a situation. And PL Gautam sir, so great efforts. So my great applause. So I'll just give a little different perspective to all the excellent inputs, valuable inputs you all have given. So when I look from the evidence standpoint, the tranexamic, the body of evidence in each condition is astronomical. So the type of patients they have recruited to see the difference. And most of the studies, as all of you have alluded, is to see whether 3 questions they have asked, whether it could reduce the bleeding. So the answer is yes, it could reduce the bleeding. Whether it could reduce the need for transfusions. That is very pivotal for a country like India, where there is a scarcity for the blood, which is obviously the cause of death. Whether it could reduce the need for transfusion, the answer is yes. And the third holy grail that we all look for is the mortality. So obviously, there are 2 important conditions which all the expert panelists have alluded to, trauma and PPH, where it has without any contention, it has shown mortality. But there are other conditions where there's a lot of studies, because in fact, this whole debate came to our mind when I discussed with Anirban. What about in upper GI bleed? Because we looked into the body of literature. Can you guess the number of patients that have been included in certain studies? There was a recent 2025 meta-analysis, 2 million patients, 2 million patients, they have looked at the data. And I was very curiously looking into this article, which came in 2025, where in upper GI bleed, it has shown mortality reduction and reduce the need of transfusions and the rebleed. But having said all this, there is a devil's advocate in all this. So why this is so heavily contested? Because even the risks are there, because all the studies have looked into the thromboembolic events, which obviously all of us have to be very wary of when we are using this drug in an overzealous way. Because this in upper GI bleed, it was shown to increase the thromboembolism. That's why we sort of not use it in an overzealous way. Even in traumatic brain injury, because recently we had a patient of polytrauma, we used it, and this patient had a right carotid artery thrombus with a huge infarct. So there is a subset of patients where it has shown huge benefit, but overzealous usage is fraught with the risk. So this is the sort of a evidence which is so fluidic in nature. Yes, it has a role. As Kapil rightly pointed, the dose and the duration and how many days we use becomes quintessence. We try to overzealously use it. The long-term mortality may be high with the usage of this, and maybe there are certain subgroups where this cannot be used. I think I rest my case, but excellent discussion from all of you. So it is an adjunct, So it has a role to play, but we have to be absolutely clear about the timing of the drug, the dosage of the drug, and the subset of the drug. That is my
Thank you,
submission,
Pradeep.
Nirban.
Thank you so much. And I think, in an absolutely befitting note, the jury today has decided not to vote and declare both the members of the Treasury and the opposition as winner. And I think that is a very wisely taken decision, because both the teams had raised the bars of this debate, while Gautam sir had brought out specifically the Jehovah's Witness case to cite that blood people can survive without blood transfusion, to which Dr. Rupta sir had strongly contradicted by citing the other figures to suggest that blood is life, and a drug cannot be a replacement for life. So we had an excellent debate. We will be having more such debates in the coming days. And before that, now the debate has ended, but yes, there are a lot of queries in people's mind, and Dr. Rumta sir also had to say a few more things that which he probably missed out during his debating part. Yes, sir.
Can I just make one point here, Anirban? Just
Yes,
one that Pradeep rightly brought out the the body of evidence. We should never kind of be. It is a very zealous investigation which was done, trials which were done, and one is a Lancet 2017 publication, the other one is 2024 publication, that is Woman 1 and Woman 2, and they have randomized more than 15,000 women in each of these trials. So I think it is a high quality evidence. More than 120 centers were recruited both times. So it is a good quality evidence. So we have to work along with evidence. That is what we are doing in obstetrics.
Thank you, madam. Rumta sir.
Anirban and jury, today's debate had three major points. One is the current Indian scenario,
Yes.
castigating India as a poor country which cannot afford to develop and erect blood banks. So the debate has to be in relation to the topic. Another is pitting
investment.
tranexamic acid against blood banks.
Yes, investment.
And third is investment.
Yes.
So there are three issues. So, today I am in the hills of Uttarakhand at a place which has a population of 20,000, in a hospital, charitable, fully, free, everything free. I am here to promote a blood bank costing 3 crore rupees.
So very contextual, sir. Very contextual that your presence has added so much value to this debate, sir.
Now you see, what I mean is development of blood bank is on the priority of organizations, governments, and people at large, and it is needed. I am here for two purposes: intensive development of intensive care. I have closed my practice in Jaipur to help all these developments in remote areas. So, and we are developing 4 storage centers, one at Kedarnath, one at Badrinath, and 2 on routes to Kedarnath and Badrinath, because there are lots of accidents and disasters. So, main blood bank at the place where I am, about 40 kilometers from Dehradun. So my broadband is not very healthy. Number 2, India, it's only, decision making by politicians and bureaucrats, how much to lay out for blood banks. I am telling you today, if we have 56 lakh blood banks in our country, in 2 years' time, we will have about 90 lakhs, about crossing to about 75 to anywhere near 80 to 90 lakhs of bigger and smaller blood banks, which includes storage centers. So when it comes to tranexamic acid, there is no question, as a drug, it is an essential drug. But there is no place for comparing it with investment into blood banks. So that is my,
Yes, yes, sir. That was the point. Of the
prayer
debate.
to the jury.
Yes, Gautam
before
sir
they
also wants to add
pronounce
something.
judgment.
Yes, Gautam sir. Last comment. Yes.
Ultimately, Dr. Gupta, sir, presented dramatically, but ultimately he also said it's a medicine, it's essential medicine, it's required. And secondly, if you work in the very advanced centers, in anywhere in the world, the top one, if the patient is bleeding, it takes time and it's not easy to have the vessel transfer protocols. And
Yes.
acid can reduce the
No,
blood
not
loss.
only Rumka sir. WHO says that. WHO says that it is an essential medicine. Yes. So friends, thank you very much for participating in this debate. The jigs face off, the clash of opinions. We will be having more clashes in the coming days on the 4th Thursdays of every month with more stalwarts like Rumta sir, like Gautam sir, like Monalisa and Pooja. We will have more enthusiastic debaters and who will open up new vistas on contentious issues to enrich ourselves with more information and insights. Thank you very much. Till we are back with our JIX Rapid Journal Review, from all of us in JIX, Shubhratri, Shabar Hayat, good night.
Thank you very much.
Thank you. Thank you.
Thank you, everyone. Thank you, sir. Thank you so much.
Thank you all. Good night.
Good night.